We're going to go ahead and get started. Thank you for being here today. My name is Mandy Sandcooler, and I'm the Director of Partnerships and Communications here at The Mended Hearts, Inc. And it's my pleasure to be able to be here and introduce our session looking at the relationship between cardiovascular disease and chronic kidney disease. In a moment, I'm going to introduce our presenters, but before I do that, I wanted to go over a few housekeeping items. Please know that all attendees are in listen-only mode. We will not be able to answer any questions related to your specific condition, but we do encourage you to go back to your healthcare team to ask those questions to them. We would like you to type your questions into the Q&A box so that we can answer them at the end of the presentation. There will be some time for questions then. And please know that the webinar is being recorded and will be available on our website and our YouTube channel in the next day or so. We wanted to thank Alexion. This webinar is being brought to you with their support, so thank you. And I also wanted to mention that this webinar is being translated live into French, and so you should have seen instructions for that when the webinar started. And now to introduce our three speakers. First off is Meg Fraser. She's going to begin today, and she's going to be giving you a broad overview and kind of an introduction into the relationship between these two conditions. Meg is a nurse practitioner at the University of Minnesota in the Division of Advanced Heart Failure and Cardiac Transplant. She is an active member of the Heart Failure Society of America and American Association of Heart Failure Nurses, where she serves on multiple committees for both. She is also an editorial board member at the Journal of Cardiac Failure. And Dr. Fraser specializes in providing care for patients with advanced heart failure after heart transplant, as well as genetic cardiomyopathies and cardiomyopathy related to muscular dystrophies. Our second speaker will be Glenn Kelly. He's a remarkable individual whose resilience and determination have inspired many. Diagnosed with stage 4 Hodgkin's lymphoma as a high school senior, Kelly underwent chemotherapy, radiation, and a bone marrow transplant. After 17 years of an active lifestyle, he suffered a heart attack in 2003. His heart journey continued to include multiple stents, 2 bypass surgeries, and heart valve replacements, eventually leading to a heart transplant in 2016. Onset complications after heart transplant included chronic kidney failure and over 3 years of dialysis before receiving a kidney transplant in 2019. Today, Glenn dedicates his life to helping other patients navigate their health journeys, sharing his story and offering support through various advocacy efforts. And then our final speaker today will be Pam Winterberg. Dr. Winterberg was a practicing pediatric nephrologist and researcher for 10 years before joining Alexion, AstraZeneca Rare Disease, in 2022. As Senior Medical Director in Clinical Development, she's dedicated to finding new treatment options for people living with kidney disease by designing and running clinical trials. So a big warm welcome to all three of our speakers. I'm going to stop share now, and I'm going to let Meg take it from here.
Hello, everybody. My name is Meg Fraser, as introduced. Thank you for that introduction, Mandy. I want to thank Mended Hearts for having me today to give a talk on the connection between heart and kidney and how it relates to the rest of the talk today. So the outline for my talk will be, I'll first discuss what is kidney function. What do the kidneys do? What are they responsible for? I'll then move on to talking about the relationship between heart disease and kidney function. I'll talk about the effect of cardiac medications on kidney function and the effect of cardiac surgery on kidney function. And then I'll end with some potential target for therapeutics, be it prevention or treatment. So how we measure kidney function. So the kidneys, you have most bodies have 2 kidneys. They're organs whose job is to filter the blood and rid of waste and fluid through the urine. Creatinine is a normal waste product of muscle breakdown. It's influenced by many things, including age, sex, race, and muscle mass. In a normal kidney, patients have a creatinine of about 1 when kidneys are functioning normally. A high creatinine is a sign that kidneys are not filtering well. There's also a measure called glomerular filtration rate, or GFR, and this tells us how well your kidneys are working or filtering. A normal value is greater than 90. So a lot of our patients with heart disease also have kidney disease, and they see it either on their after visit summary or somewhere in an encounter in the hospital. And patients often say, I never knew I had chronic kidney disease. So stage 1 through 3 chronic kidney disease is common in patients with heart disease. At these stages, there are typically no symptoms, and treatment in these early stages are aimed at treating underlying medical issues with kidney-safe medications. And mostly in these early stages, the medical team simply monitors kidney function. This is another graphical to represent kidney function, if you think of it on sort of a spectrum in this way. And so normal, that GFR being the filter rate, is greater than 90. Between 60 and 90, we consider that early stage kidney disease with no specific treatment. In the orange zone of 15 to 60, usually the kidneys have some function, meaning that urine output is considered at least normal, that creatinine is elevated and the GFR is low. And then when the filter rate is less than 15, this is when we're talking about true kidney failure, and many of these patients require dialysis. Additional testing on the kidney includes, so mostly we're talking about blood testing. This is the means to monitor filtration rates and creatinine. Some patients undergo, as part of their kidney dysfunction workup, a kidney biopsy, which involved an ultrasound at the back and then a needle inserted through the back to take a sample of kidney tissue, and urine studies. So kidney function and heart disease. Abnormal kidney function, as I said, is very common in patients who have heart disease. One of these reasons is because there are similar risk factors for the development of kidney disease and heart disease, including diabetes, hypertension being predominantly the most common. And kidneys are very sensitive and sensitive to pressure and fluid. And so when a kidney is sensitive to pressure and fluid, and you have a patient with heart disease, specifically heart failure, and there are fluid shifts that come with heart failure or congestion, the kidneys are very sensitive to that. And similar with high blood pressures and low blood pressures as well. So the prognosis of kidney disease when you have existing kidney disease and heart disease develops kind of depends on how long the patient has had abnormal kidney function, and do they have underlying issues or other reasons to have kidney disease, such as something congenital. This is a very busy slide, but the point here is just that a lot of the medications that we use to treat heart disease and heart function work at the level of the kidney. So they work within the kidney. So in the center, you'll see sort of the kidney's filtering mechanism, and all the different color boxes are the different classes or different families of medications that we use in heart disease. Many of these are used specifically in heart failure, but several of these agents are used for high blood pressure, or even medications like digoxin are used in arrhythmias, heart disease with arrhythmias such as atrial fibrillation. But the point being that a lot of the medications we use for heart disease affect the kidney. There is something called cardiorenal syndrome that also plays a big role in the interaction between the heart and the kidney. And so specifically in patients who have heart failure or not normal squeeze of their heart or have an abnormally stiff heart, you can see on this diagram the two different directions of the arrows, but there are two types of a syndrome called cardiorenal syndrome that have to do with when the heart is really struggling and not squeezing well and the kidney gets congested or fluid overloaded. That affects the kidney function. And then vice versa, when there's some decline in kidney function, this can also in turn affect the heart function. There's another busy slide, but the point of this one is also, if you look at the actual physiology of the interaction between the heart and the kidney, it is very complicated. So it involves a lot of hormones and proteins and things, including, triggers from the brain. And it's a very complicated interaction, but the heart and the kidney are very much related. So let's talk about now cardiac surgery and acute kidney injury. So when we talk about cardiac surgery, what do we mean? Typically, we're talking about an open heart surgery. Then examples of open heart surgeries are a heart valve replacement or a repair of a heart valve that may be leaky or tight or stenosed. A coronary artery bypass surgery, which a lot of times we call bypass surgery. And this is when there's a blockage in one of the arteries that are on top of the heart muscle. And the surgery is meant to bypass these blocked arteries by using veins and arteries from other parts of the body. Repair of an aneurysm of the heart. So sometimes there's sort of a dilation or an outpouch of some chamber of the heart muscle, and these must be repaired. A left ventricular assist device. So this is a temporary device that's placed, a durable device, meaning a long-standing device that's placed the bottom of the heart, and it takes over the work of the left ventricle or the left side of the heart. And these patients can live on these devices out of the hospital for several years. Or a heart transplantation. So cardiac surgery of heart transplantation. Other heart surgeries that you may hear mentioned would be what we call a percutaneous valve surgery. And what's meant by percutaneous is when you, instead of having an open heart surgery through the sternal bone in the chest, you have access through a vein or an artery, and typically the leg, and you have surgery on the heart valve, but through an extremity and not through the breastbone or the sternum. And then minimally invasive surgeries. So some surgeons and some centers do minimally invasive heart surgeries, where instead of having an open heart procedure, the incision is on the chest wall over sort of the rib area of the left side, and they have their valve repaired or replaced in that way. And so when we talk about open heart surgery, this is just an example of that sternotomy. So the breastbone that is cut during surgery, and then the heart is exposed. And this is the way that the surgeons can operate on the heart. The 4 sort of tubes on the left side are called cannula. And these tubes travel out of the heart. They drain blood without oxygen from the right side of the heart to what we call the heart-lung machine, or the cardiopulmonary bypass machine. And the purpose of this machine is to give oxygen to the blood and then return it to the left side of the heart. So it takes over the work of the heart during the open heart surgery so that the surgeons may perform the surgery needed. So cardiac surgery and kidney function. Kidney dysfunction after cardiac surgery is common. So one recent study reported a 20 to 30% incidence of this. Most cases are mild, but up to 3% will need dialysis. And acute kidney injury after cardiac surgery is associated with worse outcomes and a longer hospital length of stay. So short-term and long-term mortality, this is a study that took a look at mortality of patients who developed acute kidney injury after their heart surgery. You can see the darker shaded boxes are short-term mortality, and even the light shader box are the long-term mortality outcomes. And you can tell that if you look on the x-axis on the bottom, that the outcomes are worse as you progress through the different stages of kidney injury. The same with length of stay. So ICU length of stay being prolonged as stage of kidney disease developed, but the overall hospital length of stay is also affected. So acute kidney injury after cardiac surgery. So when we say acute kidney injury, what we mean is a sudden and often reversible decrease in kidney function. And when we talk about this in the hospital, there are 3 sort of mechanisms which this happens. The first we call pre-renal, meaning before the kidneys. And this is typically when we have injury due to low blood flow to the kidneys. So this can be low blood pressure or blood loss, both of which may happen with heart surgery. Intrarenal, so within the kidney, can also experience damage around the time of surgery. And this is direct injury due to maybe medications, probably being the most likely, antibiotics or otherwise, or infection or clot. And then postrenal, so after the kidneys drain into 2 tubes called ureters into the bladder. And if there's any sort of blockage, such as a mass or a stone or a clot, or in men, an enlargement of the prostate, you can have backfill of urine up to the kidneys, and this can cause kidney injury. So how can we predict this? We talked about what it is and what is contributing to acute kidney injury at time of heart surgery. There are ways to predict this. So there are some patient risk factors. One, as I sort of alluded to, is heart failure, the presence of having abnormal heart function going into a surgery. The use of diuretics before surgery. And diuretics, for anyone unfamiliar, is water pills, meaning the medications that we use to help decongest or keep fluid off of the body. Patients who have diabetes are at higher risk. Patients with pre-existing high blood pressure or hypertension. The presence of what's called an intra-aortic balloon pump. So this is a temporary pump that we use in the ICU to help support the heart function. Having kidney dysfunction or abnormal kidneys going into the heart surgery is a risk factor. Having anemia before surgery or low hemoglobin. Age. The presence of peripheral vascular disease, so blockages in other parts of the body, arteries, meaning the legs, the arms, stroke, history, and blood vessels anywhere else in the body. And then the duration of the heart-lung machine, so the cardiopulmonary bypass support machine. The longer the surgery, the higher risk patients are to develop this. Also complex surgeries. So there are many different types of heart surgeries, as I mentioned. Some are more complex than others based on other patient factors. So how can we predict this? There's some research out there looking at biomarkers, which are blood tests that would tell us, who is more likely to develop acute kidney injury after heart surgery. One is called neutrophil gelatinase associated lipocalin, and this is a blood marker for kidney injury. Another kidney injury molecule 1. This is a protein that actually breaks off of the surface of cells and enters the urine when the kidney gets injured. And then there is a cystatin C, which is a blood marker that shows how well the kidneys are clearing, and it's irrespective of muscle mass. So this is often felt to be a more accurate measure of how well the kidneys are functioning in patients who have low muscle mass. There are some risk scores that have been developed to look at how we can predict who is going to develop acute kidney injury after heart surgery. There's an example of 3 of these that were all created from very large studies with many patients, looking at different risk factors and giving points assigned to different risk factors and so that we're able to predict who may be affected. So current target for therapeutics or treatment. Currently, we make every attempt to what we call optimize fluid status prior to heart surgery. So making sure that the patient has normal fluid status, not too dehydrated, not too much fluid or fluid overloaded heading into heart surgery. Avoiding anemia, but also attempting to avoid transfusions. So kind of optimizing anemia with iron and other things. And minimizing medications that affect the kidney, including, surveillance of kidney function during the use of antibiotics, and really attempting to avoid contrast with any CAT scan or other studies when able. So is there potential for prevention? Most interventions that have looked at prevention have been negative. So some examples are rewarming on cardiopulmonary bypass. So that's when the patients are still on the heart-lung machine, attempting to adjust the temperature, the body temperature of the patient, attempting to adjust and optimize oxygenation. Use of the medication called vasopressin has been studied to prevent this, but none are approved for acute kidney injury associated with cardiac surgery. So now, is treatment possible? Stay tuned. You'll hear in a few talks, Dr. Winterberg will discuss this. So wrapping it up, the heart and the kidneys are very much connected. Kidney disease is common in patients with heart disease. Kidney dysfunction is associated with worse outcomes after cardiac surgery. And therapeutic targets for prevention or treatment of cardiac surgery-related acute kidney injury are necessary. Here are my references, and thank you.
Thank you, Meg. And we're going to let Glenn take it from here.
All right. Cool. Mandy, thank you. Meg, thank you. A whole lot of science, wasn't it? As we all know, that part's so important. But how does it feel? That's what I'll talk about for a few minutes. As you saw in my bio, I've had a heck of a medical journey, and some of you know me. I see some friends here on the list today. Thanks for everybody joining. I did not understand the importance of my kidney function until I didn't have kidney function. And that's not uncommon. Yeah, I started with my heart journey back in 2003, and it kind of rambled along and rambled along. And well, then I had one open heart, then I had two open hearts, and then I had a transplant, and then I had another open heart after that. So you can imagine, if you remember back to a slide Meg shared, that notion of, a nice diagram of a bypass, right? So now take that times 4, and my kidney said, I'm done. So were there steps along the way that kind of were incremental to all of that? Sure. Heart failure, she alluded to, lots of diuretics. And on a funny note, I'll share, diuretics are hard, right? You're always thirsty, especially when you have to take lots of diuretics. So after I received a heart transplant, I thought, well, what's drier, really? A life on diuretics or the Sahara Desert? So I went and proved it. I went to the Sahara Desert on vacation and some other things. And I found out that, oh yeah, no, diuretics were definitely drier than the Sahara Desert. So anyone who's on today that happens to be dealing with diuretics, you have my empathy. You can tell your family that, yes, it's drier than the Sahara Desert. Now, on a serious note, as I went back and I said, I didn't really understand the importance of kidney disease until I didn't have it. And one of the things I did understand was, heart. That was like really straightforward. And I had support there that helped me through. Support which, people that have been through, some of a heart journey like mine. I had support of people who were in it when I was in it, right? And I learned from them. I learned from their experiences. I became educated about heart. And everyone on here today is being educated. And I encourage you to take what you've learned, not just for yourself, but share that with others. Share that with others that you support. It's invaluable. So by the time I got to kidney disease, I'd lost, I'd gone all the way in the deep end and started dialysis. I realized, wow, this is a different game altogether. Where's my support? Because I had such great support with heart. And it took some time to find it. I found pieces here and there. But as I found, a kidney journey was different than a heart journey. I also found the difficulty, like in dialysis, and do anything you possibly can to take care of yourself so you never need to get to dialysis. I will share, I'll tell anybody this, having had, a year of chemotherapy and radiation versus 3 years of dialysis, dialysis was more difficult for one reason: support. There's all kinds of great support for cancer. Patients out there, there's great support that we have here for heart patients. I encourage you to offer support for those with kidney disease, because it's not quite the same. They have different challenges. Many still can work and have to work. Many, it's kind of like, well, you look okay, so you must be okay. You don't have the same kind of outward symptoms. So offering support to those with kidney disease can be very powerful. And so I encourage everyone on the call today to look to that. So I eventually found kind of my little place of support with kidney, and it was invaluable. Eventually, I was able to receive a kidney transplant. So yes, I got a heart transplant, and 3 years later got a kidney transplant. And so having support being so central to my success, well, this is why I'm here with you today. So I encourage all of you to, I know you're all supporting others that are on the call today. And I encourage you to kind of take that extra step. Next time you talk to a heart patient, ask them how their kidney's doing, because I'll throw one out here. Many people that I know kind of use this reference about their toddlers. When they're happy, they're joyous, they're bouncing around. And when kidneys aren't happy, they're like a toddler. They are screaming babies. So you won't know that unless you ask the person, how's your kidney? Or kidneys, excuse me. I'm used to doing a singular kidney because I have one. When you transplant a kidney, you only get one. You only need one. And also, while I'm here, anyone who's eligible may want to become a living donor of a kidney, because there's a massive shortage of kidneys as there are hearts, but it's very significant in the kidney space. So anyway, with that, I think I'm going to turn it over to Pam, and she's going to talk about a potential treatment that sounds really exciting that can help curb the impact on your kidneys when undergoing some of these cardiac surgeries. Pam, take it away.
All right, my slides up here again. Thank you again, Glenn and Mandy and Meg, for inviting us to here. Get you up here. So as we said, my name is Pam Winterberg. I am a pediatric nephrologist, so that's a kidney specialist for children. That's kind of what I did before I joined Alexion, which is the sponsor of today's webinar. But now I run clinical trials trying to find new medicines for people living with kidney diseases. And today I wanted to share with you a trial that Alexion is currently conducting called the Artemis study. It's for CKD patients to prevent kidney injury during and after heart surgery. Trying to get it to advance. There we go. So we've heard a little bit about the connection between the heart and the kidneys, which was great. You've also, I think, already heard a little bit about what acute kidney injury is. So this is a sudden decrease in kidney function that usually occurs over hours or days, and it's typically due to damage to the kidney cells themselves. The signs or symptoms can be rather vague. Unlike a heart attack where you feel the injury to the organ, kidneys, you may not feel the damage happening in the moment. But we see signs like a change in the blood creatinine level. As Meg had mentioned, if the creatinine level is going up, it means the kidneys are not filtering that waste product as well. And so it's a sign of injury. Similarly, there can be a decrease in the amount of urine that your kidneys make. So you may have to go empty your bladder less frequently or have less to empty. The kidneys, really their main job, in addition to clearing and filtering out the waste, is to keep a lot of things in balance in your body. And when they are not working very well, you can have changes in the blood acid level or salt levels that normally are kept in balance by the kidneys. And that has consequences beyond it. Again, you may not feel differently, but your heart may not like those changes. And then finally, one of the other balance is the amount of fluid in your body. I think we all intuitively know the more you drink, the more you pee, or the more urine you make. And so when the kidneys are not able to maintain the fluid balance, patients can experience a buildup of fluid in multiple parts of the body. It can be generalized swelling, so all your tissue is swollen, or it can be increased fluid around the lungs or around the heart as well. Meg did also a nice introduction about what causes AKI, and the kind of two big buckets of types of injury that are the most common after a surgery are decreased blood flow to the kidneys. We'll talk a little bit more about that, and certain medications, but Meg did an excellent job going into those details. So there's currently no approved medicines to either prevent or treat AKI. So right now, it is managed by treating the symptoms of the acute kidney injury event. That can include using medicines to increase the urine flow, like the diuretics that are also already used for heart failure. We may need to restrict what types of nutrition or medications that can be used when the kidneys are not working well, because those either nutrients or medications can build up in the body when the kidneys aren't able to clear them. Sometimes we temporarily use dialysis. There's some forms that are only used in the hospital for a short-term treatment. But ultimately, what Glenn was talking about was more a chronic type of dialysis. But that helps manage some of the excess fluid or the chemicals or waste products that are building up in the blood while the kidney is injured. And then if there is too much fluid in the lungs because of the acute kidney injury, some patients need to have the breathing tube and a ventilator to support the body until we can get that excess fluid out of the body. And ultimately, this all comes down to, again, managing the symptoms while waiting for and giving time for the kidneys to heal after the injury. So we're talking about AKI during heart surgery, but this can happen in other settings too. It's one of the most common complications of a hospital stay because the kidneys, as Meg said, are pretty sensitive to low blood pressure. And so when your whole body is sick, the kidneys can be sick. But there are certain particularities about heart surgery. So first, the open heart surgeries and some of those minimally invasive surgeries Meg talked about use that heart-lung pump or the cardiopulmonary bypass machine. And being on that pump has a much higher rate of injuring the kidney than being off the pump. One of the other things we talked about not having symptoms at the time of the organ damage, but even following those blood levels that she talked about, the creatinine is the most common. Some of those other biomarkers are not readily available in the hospitals yet, but it can take several days for those to be noticeably high enough to know that the AKI has happened. And so it might be a little late before to treat. By then the injury's done and it's just trying to recover. So there has been interest in trying to prevent kidney injury to either stop it from happening altogether or make sure that it's not as severe so that we don't have as long of a recovery period afterwards. For heart surgery as well, we assume we have a better idea of when the injury is happening because the highest risk events are during the surgery itself, where other types of acute kidney injury, we don't know when the kidneys were injured since there aren't symptoms. So having a known schedule of when you're at the highest risk for injuring the kidneys allows time for us to give a preventative treatment before the injuries occurred. I won't spend too much time on this one either because I thought Meg did an excellent job talking about the heart-lung machine or cardiopulmonary bypass. It essentially takes over the role of the heart and the lungs while the surgeon is operating on the heart. But it's a temporary replacement. It's not what your organs are normally used to seeing. And so what happens when you're on this pump, it's keeping you alive while the surgeon's doing their work, but it can really stress the kidneys in particular. They're just very sensitive to this kind of injury. And ultimately, we end up with this vicious cycle of inflammation. Part of it is due to a change in the way the blood flow is done on this pump versus in your heart when your heart is pumping the blood. And if there's a combination of the kidneys already not working at 100%, having some pre-existing kidney dysfunction or chronic kidney disease makes them more sensitive to this type of injury from the blood flow. So when the kidney cells are stressed or injured, they can trigger inflammation themselves. At the same time, the blood vessels with the pump can also be inflamed, and that can go back to the kidney and stress the kidney out further and cause more injury in the kidney. And then finally, there's this transition period. Ultimately, a patient needs to come off of the pump and the heart starts beating again. And that can be a bit of a shock back to the system, especially the kidney cells that were stressed or injured already. It's called a reperfusion injury. So there's those complicated diagrams are very much the state of our understanding of that connection that Meg had shown. But simplified down, part of this inflammation can be started or worsened by uncontrolled activation of a part of our immune system called the complement system. And that's the focus of the Artemis study. So how do we find new treatments for AKI or really any condition? It's through the conduct of clinical trials. Those are scientific studies that are designed to answer two main questions. One, is a treatment or therapy effective? Does it work? And two, is a treatment safe? And there's always a balance between these two. The Artemis study is a phase 3 randomized, double-blind, placebo-controlled clinical trial that is studying whether the blocking of complement activity during that cardiopulmonary bypass reduces the risk of major adverse kidney events at 90 days in people living with CKD who are undergoing heart surgery. So that's a lot of vocabulary. Let's dive into that a little bit. So phase 3 is the technical term for the type of study that is required to get approval from health authorities around the world, including the FDA in the US or the EMA in Europe, in order for a medicine to be sold as a treatment for a specific disease or condition. And this is the most rigorous type of trial. So in order to establish that rigor, it's the highest standard of any clinical trial, there are three components. So that's those next three words. Placebo-controlled means that some participants receive active medicine while other participants receive an inactive substance. And those typically look exactly the same. That becomes important in a minute. Second is the word randomized. That means each participant in the clinical trial will receive at random either active or the placebo. So they get assigned to one or the other, and it's chosen at random. We don't know how to choose for them. It's a computer. So the last part is double blind. This means that everybody involved in the clinical trial, so the study participant themselves, the patient, the healthcare providers taking care of the patient, as well as anybody on the study team, including the sponsor, like the drug maker, do not know which individuals are receiving the active medicine and which are receiving the placebo as long as the trial is ongoing. So at the very end of the study, everything will be revealed. But at the time, the knowledge of whether they received the medicine or the placebo is hidden so that it doesn't affect how we measure anything that happens after you get the treatment. Okay, so it's the most objective way of doing a study. So the very large view of the Artemis study, participants who are interested in joining the study undergo an informed consent process. So they learn about all of the risks and benefits of the study and have a screening visit to confirm that they are eligible for the study. And that can happen up to 35 days before the surgery. Each participant receives a single intravenous, so those IV infusions of either the placebo medicine, so that inactive substance, or the medicine under investigation called ravulizumab. And that infusion occurs 1 to 7 days before the surgery. So we're trying to block the complement or have the placebo in before the surgery. Then there are study visits occurring for the 90 days after the surgery. A few of them are during the hospital stay right after the surgery, and then there are several after the patient goes home. And most of that is focused on how the kidneys are doing, so more the blood samples that Meg talked about. We're monitoring for whether you need dialysis, if the patients are still alive through that 90 days, that they've survived their surgery, and then a few other questionnaires about how you are functioning and your quality of life. But ultimately, at the end of the study, we're going to be comparing to know for if this treatment's effective, if the number of participants in each treatment arm, placebo or ravulizumab, who experience major adverse kidney events within those 90 days. So let's see what that is really about. So we've been talking about AKI, which is what the doctors and the nurses are looking at for and treating after the surgery. However, in order to determine the effect of a treatment, a preventative treatment even, we have to show that it improves the events that happen as a result of the AKI. So that's what is called major adverse kidney events. It means if a participant experiences any one of the following in those 90 days, then they will have been considered having the event, the MAKE event. So if you die after your surgery before the 90 days post-op visit, if you need any temporary dialysis between the time of dosing and that 90 days visit, or at 90 days, if you're still alive and haven't needed dialysis, if the kidney function is decreased by at least 25% from where it was before the surgery, that would also be considered a MAKE event. So it's related to AKI, but it's not exactly measuring AKI, if that makes sense. So who is eligible to participate? We are enrolling adults aged 18 through 90 years at the time of consent who are needing non-emergency surgery for coronary artery disease. So that's that coronary artery bypass graft or CABG that Meg talked about, or heart valve disease. So any of the valve repairs or replacements. Because of the high risk for AKI, we have several inclusion factors for the risk of AKI. That includes already having chronic kidney disease with a GFR between 20 and 60, and then a few other risk factors for those kidney events. That is dependent on how much kidney function you start with and what type of surgery, because the longer you're expected to be on the bypass, the higher risk you are for the events. That's considered a risk for the surgery. Who may not be eligible for the study include participants who need an emergency heart surgery, so they can't wait for the study procedures and it's life-threatening. The surgery, if it's not going to be on the pump, so it's not necessarily has to be open heart with the big sternal open wound, but as long as they're on the cardiopulmonary bypass machine, that heart-lung pump is what's required. If you are already receiving dialysis before the surgery, we can't enroll in the study because that's one of the outcomes we're looking to prevent. And then if you're already experiencing AKI before the surgery. And then finally, those who already have an organ transplant, just because their risk and treatment is already different before the surgery. So to wrap up, AKI during and after heart surgery is caused mostly by a decreased flow to the kidneys, as well as inflammation that's occurring during that heart-lung machine called the cardiopulmonary bypass pump. People living with CKD are at higher risk for these major adverse kidney events after the heart surgery. And the Artemis study is evaluating a new treatment that can be given before surgery to reduce the risk of those kidney events after surgery, especially those that are at high risk living with CKD. We have some websites here if you are interested in learning more about the study, including the study design listed on clinicaltrials.gov. I know I didn't have a slide about it, but the study is being conducted in approximately 20 countries around the world. And so, yes, it is a global study wherever you're at.
Thank you, Pam. And if you could just go ahead and stop sharing your slides, we will bring all of the presenters up on screen to answer questions. I'm wondering if we lost Pam. Oh, there we go. Good. And so, yes, thank you. If we could spotlight Glenn and Meg and Pam, Tammy, that would be great. If you want to put your questions into the Q&A, we've had some comments in the chat, but nothing related to the presentation right now. I have a couple of questions. My first one is to Glenn. Glenn, for all those folks out there who may not have ever participated in a clinical trial or who may have some reservations, what are some of the benefits for patients to participate in clinical trials, and why should they do it? Why is it so important?
That's a great question, and I'll make a deal, Mandy. I'll answer it, and then I'd like Meg to say as well, because I know she's been hands-on involved with patients in clinical trials as well. So a couple of good perspectives there. Pam, I'm sure you have it too. Anyway, so I don't know how many clinical trials I've been in because there have been too many. I shouldn't say that. There's been just enough. I know that I wouldn't be here today were it not for at least one of them. My original cancer therapies were a clinical trial, and we're still early clinical trial. And had I not taken advantage of those, I wouldn't be here. I know some other clinical trials, actually, I'm just kind of thinking through my head, and they were kind of easy. I mean, it was just like, oh yeah, we're good. Trying to think of one of them off the top of my head, but it's just like, oh, okay, you're gonna look at some DNA while you're doing all my blood work to see how it compares to another group on how I'm responding to a therapy which has already been approved by the FDA. So really little risk, if any. And so it was like, oh yeah, okay, sure. Can I have another sandwich? I mean, it was that easy. So, but incredibly beneficial for myself personally. And I know people that are actually benefits of some of those therapies that I'd had in the past going forward. Meg, what's your point of view?
Yeah, I would say, you know, mostly just to provide some reassurance. I think by the time a medication gets to phase 3 trial, there's been so many, and Dr. Winterberg mentioned this, but there's been so many studies on the medication leading up to that point as far as safety and everything else. And so by the time it's being offered or discussed with patients, hopefully patients can feel confident that this has gone through several sort of, steps already by the time it's reaching patients. I understand, talking to a lot of patients about clinical studies, especially when it involves medications or different treatment rather than just, as Glenn was mentioning, the types that we're monitoring or surveying. Just feeling confident that, for a medication to be at that phase, they haven't seen significant safety concerns or anything. And also to Glenn's point too, I mean, a lot of what we do in regular practice or what is standard of care now, at some point, the reason why we use these life-saving medications and cardiac disease or anything, or techniques in surgery or anything, was the result of clinical trials. And so by participating in clinical trials, I think, at some level, every single patient in a trial is contributing to science.
Yeah, I'll weigh in a little bit too. I think it's also knowing that the clinical trials have to go through multiple rounds of review by not just the people conducting the trial or the people recruiting into the trial, but there are ethics committees at every institution, and every country's health authorities review, what is proposed as the protocol for the clinical trial. And an important part of that is the risk. What is the risk of participating or not participating versus the benefit of participating and not participating? And that's very similar to what we do every day when we're taking care of patients in the hospital, but may not be as obvious in that setting as it is in the trial. It's very much discussed in full, the risk and the benefit of either, right?
Pam, you brought up a good point that I just want to share with folks as a personal experience. One of the ways I got involved, in addition to just providing support and patience, is, and I kind of, maybe this under my advocacy hat, but I actually participate in one of those review boards that you speak of, right? So FDA mandate, any clinical trial and every clinical trial has to have review by third party peer review medical reviews. It's called an IRB. And as part of that, mandated, a non-affiliated reviewer has to be involved. It's best when it's a patient, but there can other be people not associated with, like, in a given institution for research, certainly not the sponsor at all of the study.
Right.
And so as a patient, I review those. And I get a queue of them every other week. And I look at them from the lay perspective, because what do I know? I had a music degree. So, but what I can tell you is, like, oh, wait, when we're filling out an informed consent, okay, can we really understand this or not? Right? And we're looking at the safety of it, right? And we're looking at, is there truly a benefit? And then there's continual reviews that happen on them once they're approved. And any changes have to go through the same process. So that's an incredible safety net that's there, to know that people, experts are looking at, your trial, if you're in a trial, other than those that are treating you and those that are sponsoring the effort as well.
So we, just to further iterate on that, I talked about how everybody involved in the study is blinded, but during the study, we also have a complete independent safety review board that does know who is getting treatment and who is not getting treatment. And so they're also one of our checks and balances during the course of a study to make sure it's still safe and appropriate, that risk-benefit ratio, while participants are in the study. Right? We don't wait till the very end to know everything about the safety, but they're completely independent. They can't be part of the study. Yeah.
Thank you, guys. We have a few more questions. Ulrich is asking, Pam, do you have a sufficient number of patients to participate in Artemis? What number are you looking for? And I had a question, do the participants have to be on site? Is it an on-site clinical trial, or can participants be remote?
Yeah. So I'll start with your question first, because that's a really important point, because it has to be, there's a lot of information or blood samples collected during and after surgery. It is an on-site, for the most part, it's an on-site study. You have to be at a hospital that is for the surgery that is in part of the study. But we do have options for those later visits after you go home to have home health, a nurse come to your home or other place closer to home if that's allowed in your country. So we try to find that right balance, because we know it's a long time. When you're in the hospital, it's kind of just part of the same care that you're getting, but you may not have a few extra visits to come back and see us. I think that's actually, when I'm thinking back, before I joined the company, I also was in the hospital helping clinical trials there. And sometimes an unspoken or hidden benefit is that you may see your physicians more frequently on the trial than you do in the normal care. You may have extra lab work. like the kidney function part in this trial. Some surgeon, some people after surgery aren't as aware about their kidney function. So that's all access. You have access to that information as a patient in the trials too. Sometimes there's just a different benefit. It's not the same as the direct benefit from the medicine, if that makes sense. The number of patients is currently expected to be 736 globally. There's very special math that is performed to estimate the number of patients needed in between the two types of treatment. But sometimes we can use in clinical trials what are called interim analyses. So that's where that independent board can determine if the study needs to stop because we already see such an overwhelming effect that it doesn't make sense to continue. We stop early. Or conversely, let's stop early because there's either a safety problem or it's not working at all. And so it doesn't make sense to continue. So that's a long-winded answer, but 736 is what we're looking for. And we are tracking towards that. We've been actually enrolling for a little over a year and a half. Yeah.
Right. And Pam, for the trial, if anyone has questions, they can email us at info@mendedhearts.org and we can pass those along to you as well. Yeah. And then I think we have time for one more question. And I think this is to Meg and or Pam. Aaron had bypass surgery several years ago, but this is the first that he's learning about the relationship to CKD. So what are the risks that he could have suffered or that he'll develop CKD later in life? Like, is that a possibility where people see that acute injury develop later on? And Meg, maybe we'll let you answer first and then Pam can follow.
So I think, the development of a AKI years after bypass surgery wouldn't necessarily be something that someone would experience. But having had a bypass surgery, for most of the time when you have a bypass surgery that bypasses blocked arteries, it's due to sort of cholesterol buildup and plaque buildup in the arteries. Sometimes people have bypass surgery due to other artery problems or blood clots, but most of the time, not knowing exactly your situation, it's sort of due to a buildup of plaque in arteries. And so by sort of having had blockages, if that was the case, or anyone who has had cases, there is just some of those shared risk factors that I mentioned. So it all kind of depends on other medical problems someone may have. So if they have longstanding hypertension, if they have diabetes, being kind of the two primary ones, those are certainly risk factors of developing chronic kidney disease in the long run over several years. So treatment aimed at, treating the underlying causes or the other, comorbidities, as we call them, but the other medical problems that contribute to any artery health would be a means to prevent sort of the progression of any kidney disease. I imagine if you are somebody who still sees a cardiologist or even a primary care doctor on any regular basis, kidney function is one of those things that's checked pretty regularly at annual exams or changes in medications or otherwise. So I hope that answers your question. Maybe Dr. Winterberg has additional input.
Yeah, no, I think it's really comes down to the individual. I think Meg presented the frequency of AKI. It's not uncommon, but most of the AKI that happens is mild and short-lived. But if you are an individual who happens to experience a severe AKI and need dialysis, it's more impactful to you, right? So the key really is understanding your individual risk for the AKI. And you may not realize it, but a lot of times the doctors taking care of you are making some of these calculated risk benefit ratios in their head. They just may not be sharing every single one with you, but it's good to have that conversation with your doctors about what are my risks, what can I expect, what kind of complications happen after, what should I be on the lookout for, so that really your care can be tailored and you understand, what to expect.
Yeah, I'm going to add a quick add on that too, if I might.
Yeah.
So I'm going to simplify it. If you're worried about it as an individual, check with your primary care doc.
Yep.
The simple blood test. They can tell you, hey, we think your kidneys, yep, we think they're good, we think this, we think that.
And I think the point being too is, let's say you don't have totally normal kidney function. In most cases, it can, can be the same for, as I kind of mentioned on one of my slides, it can be the same for several years, not have symptoms. The important thing is just looking at what can I, optimize. So making sure blood pressure is controlled. Again, if you have diabetes, make sure your diabetes is controlled, weight control, some of those other things, all the heart healthy practices and artery healthy practices also help the kidneys. So
Very true.
Great. Well, thank you. We are at the hour. It flew by, but you presented such excellent information. Thank you to all three of you and our viewers for being on. We appreciate you. And you'll be able to see this. It'll be on YouTube in the next day or so. So everyone have a great day and thanks again.
thank you.
Thank you.